Hi class, this is Dr. Chapman. This presentation is designed to accompany Jarvis Chapter 12. Please review the chapter prior to listening to this presentation. As you know, assessment of the skin, hair, and nails is usually integrated into the head-to-toe assessment. This presentation will focus on common abnormal findings of the skin, hair, and nails. We begin by collecting subjective data in the health history. We question the patient about past history of skin disease, allergies, hives, psoriasis, or eczema. Have they had a change in pigmentation or color of the skin? Note any changes in moles, such as size of moles, shape, color, or tenderness. Have they experienced excessive dryness or moisture of their skin? Any pruritus or itching, excessive bruising, rash, or lesions? Be sure to question the patients about medications, prescription, or over-the-counter. Additional subjective data includes questioning the patient about recent hair loss, change in the color or shape of their nails. Have their nails become increasingly brittle? Ask the patient about exposure to environmental or occupational hazards, and question the patient about self-care behaviors related to their skin. As you prepare to examine the skin, you need to pay particular attention to skin characteristics. You will need strong lighting, gloves, pen light, and a small centimeter ruler. For special procedures, you may need a Woods light and a magnifying glass. Consciously attend to skin characteristics. The danger in skin examination is one of omission. The skin assessment will be integrated throughout the examination. You should scrutinize the outer skin surfaces first before concentrating on the underlying structures. Be sure to separate the areas within skin folds, such as under large breasts, under the obese abdomen and groin, and inspect them thoroughly. These areas are dark and warm and moist and provide perfect conditions for irritation or infection. Always inspect the feet, toenails, and between the toes. Individuals may seek health care for skin problems, and assessment may be focused on the skin alone. Assess the skin as one entity. Getting an overall impression helps reveal distribution patterns. Inspect all lesions carefully. With a rash, check all areas of the body, as you cannot rely on the history that the rash is only in one location. The skills that you use are inspection and palpation, because some skin changes have accompanying signs that can be felt. When inspecting the skin, note general pigmentation, freckles, moles, and birthmarks. Note widespread color changes such as erythema, cyanosis, jaundice. Note if color changes are transient or due to pathology. Use the back of your hands to palpate skin temperature. Of course, the skin should be warm and equal bilaterally, suggesting normal circulatory status. Check for vascularity or bruising. Note diaphoresis or dehydration. Inspect the skin for lesions. If any are present, note color, elevation, pattern or shape, size and location, and distribution on the body. If exudate is present, note color and odor. A Woods light may be used to detect fluorescent lesions. Use appropriate terminology to document lesions. The terminology on the slide will be on the test. When examining the hair, note the color, texture, and distribution of the hair. Inspect the scalp for any lesions. Inspect the shape and contour of the nail. Check the profile sign. View the index finger at its profile and note the angle of the nail at the base. It should be about 160 degrees. Note the consistency of the nail, the color. Check for capillary refill. Check for clubbing. The following slides have some terminology that may be helpful in describing lesions. Annular or circular, confluent, discrete, gyrate. Hemangiomas or port wine stains are often birthmarks. Telangiectasias or spider or star angiomas or venous legs are often found on the nose or face. Lesions caused by trauma or abuse are called pattern injuries and can be noted in the slide here. Lesions caused by trauma or abuse include contusions. Note the variant color of contusions that occur at different times. Now we'll go over some of the more specific skin conditions that you'll see, or more common skin conditions that you'll see in your practice. First, let's talk about allergic contact dermatitis. Patients with ACD, allergic contact dermatitis, require a much more detailed history compared to those with other dermatologic disorders. Individuals with ACD typically develop dermatitis within a few days after being exposed to an allergen. However, certain allergens, for example neomycin, penetrate the intact skin poorly, and the onset of dermatitis may be delayed up to a week following exposure. A minimum of 10 days is sometimes required for individuals to develop specific sensitivity to a new allergen, so the development of ACD varies widely. Poison ivy is a classic example of acute ACD in the U.S. For example, an individual who's never been sensitized to poison ivy may develop only a mild dermatitis in the weeks following the initial exposure, but typically develops severe dermatitis within 1 to 2 days on the second and subsequent exposures. ACD to workplace materials may improve initially on weekends and holidays, but those with chronic dermatitis may not demonstrate the typical correlation of weekend and holiday improvements. You may see this with latex allergies in your own workplace. ACD lesions are sharply demarcated, occurring at the site of allergy exposure or contact, and develop over 48 hours. Initially there's redness and itching, following by crusted vesicles and blisters, which becomes thickened skin with time. Think of the last time you had poison ivy and you have a picture of contact dermatitis. This is a classic picture of an allergic reaction to a medication. I'm sure that you all have seen this before, and as you know that the hives and rash that occur in reaction to drugs vary widely. Tinea corporis, or ringworm, is caused by a tiny fungus known as a dermaphyte. These tiny organisms normally live on the superficial skin surface, and they can induce a rash or infection. The disease is acquired person to person or animal to human. Ringworm commonly occurs on pets, and it can be acquired while petting or grooming an animal. It can also be acquired from animals such as horses, pigs, or ferrets. It can be spread by touching inanimate objects like personal care products, bed linen, combs, athletic gear, or hairbrushes. People who live in crowded, humid conditions are at higher risk, and sweat can produce a humid, wet environment where ringworm thrives. Tinea pedis, or athlete's foot, commonly is used to describe pruritic, scaly soles and often painful fissures between the toes. Patients have vesicular or ulcerative lesions. Patients, especially elderly persons, may simply attribute their scaling feet to dry skin. However, as you know, this is a fungal infection. Psoriasis is an immune-mediated disease that affects the skin. It is a lifelong condition of which there is currently no cure but various treatments that can control the symptoms. Psoriasis has been linked to increased risks of stroke and vascular disease. There are 5 types of psoriasis: plaque, guttate, inverse, pustular, and erythrodermic. The most common form is plaque psoriasis. In plaque psoriasis, skin rapidly accumulates at sites across the body and gives the skin a silvery white appearance. This disorder is a chronic recurring condition, and it varies in severity from minor to complete body coverage. Here we have on your left herpes labialis of the lower lip. Note the blisters in a group on the lower lip. Herpes labialis is an infection of the lip caused by herpes simplex virus, HSV1. An outbreak typically causes small blisters or sores on or around the mouth, commonly known as cold sores or fever blisters. The sores typically heal within 2 to 3 weeks, but the virus remains dormant in the facial nerves, periodically reactivating to create sores in the same area of the mouth or face as the original infection. On your right, you have shingles caused by the varicella zoster virus, the same virus that causes chickenpox. After a person recovers from chickenpox, the virus remains in the body in a dormant, inactive state and can be reactivated as shingles later in life. Now we move to malignant tumors of the skin. But here we have basal cell carcinoma, BCC. This is the most common skin cancer in humans, yet it accounts for less than 0.1% of patients' deaths due to cancer. Basal cell skin cancer typically appears on sun-exposed skin. It's very slow-growing and rarely metastasizes. BCC usually appears as a flat, firm, pale area that is small, raised, pink or red, translucent, shiny, and waxy, and the area may bleed following minor injury. Tumor size can vary from just a few millimeters to several centimeters in diameter. Clinically, a red, well-circumscribed macule with minimal scale is present. Cutaneous squamous cell carcinoma, SCC, is the second most common form of non-melanoma skin cancer. BCC is the most common. It accounts for 20% of cutaneous malignancy and 90% of head and neck cancer. Unfortunately, unlike most BCCs, SCCs of the skin are associated with a high risk of metastasis. Most SCCs are readily identified and can be removed in the physician's office as a minor surgical procedure. Larger and more invasive lesions may require aggressive surgical management. Now we move to the dreaded malignant melanoma. Patients with melanoma usually present with skin lesions that have changed in size, contour, and configuration. You see a typical picture of a malignant melanoma in the slide. Patients usually present with skin lesions that have changed in size, color, contour, or configuration. The acronym ABCDE is the hallmark of international public awareness campaigns and may be used to remember the physical characteristics suggestive of malignancy. ABCDE stands for asymmetry, irregular border, color variations, especially red, white, blue tones in a brown or black lesion, diameter greater than 6 millimeters, and elevated surface. Lesions may itch, bleed, ulcerate, or develop satellites. I would like for you to review page 219 in your text. I want you to know page 227, the dangers of indoor tanning, and I'd like for you to print out indoor tanning fact sheet that you can find at the hyperlink on this slide. I'd also like for you to study the chapter 12 so that you can do a physical assessment of the skin. The physical assessment of the skin is summarized on page 211 and through 218. I hope you all have a wonderful weekend, and I'll see you on Tuesday. Bye-bye.